Hello, you are listening to the Natural Healing Show for UK Health Radio. I'm your host, Catherine Carrigan, medical intuitive healer, Amazon #1 best-selling author. You can find out more about me and my work at catherinecarrigan.com and unlimitedenergynow.com. While you're there, definitely sign up for my newsletter so you can learn even more about how you can heal yourself naturally. Our guest today is Nick Trott. Nick Trott is a specialist celiac dietitian at the Royal Hallamshire Hospital in Sheffield. You can find out more about Nick Trott and his wonderful work at sheffieldgastro.nhs.uk. Welcome, Nick Trott.
Thank you, Catherine. Thanks so much for having me on. It's a pleasure and an honor to be here all the way from sunny Sheffield in the UK.
There you go. Now, Nick Trott, you are a celiac dietitian. Can you explain for our audience what exactly is celiac disease?
Certainly, Catherine. So, celiac disease is an autoimmune condition. It's not a food intolerance or a food allergy, those are separate conditions. And the cardinal sign of an autoimmune condition is basically, and a sort of way I like to understand it, if you can imagine the immune system, its normal job is to help protect us in many ways. At a very simplistic measure, it protects us against, things like germs, viruses, and bacteria. But autoimmune disease is when the immune system has gone rogue and it starts attacking us. So it starts attacking the host. And that can manifest in several different ways. If you think of perhaps a more well-known autoimmune condition like type 1 diabetes, the pancreas gets affected. In celiac disease, you get autoantibodies to the lining of the small intestine. That's a classical way that it presents. So at some point, the body starts thinking gluten is attacking it, if you like, and the body responds by producing an inflammatory response, and the gut is an innocent bystander. So the mucosa of the small intestine, if you like, is an innocent bystander that gets damaged and inflammation occurs, and that eventually results in what we call villus atrophy. So the lining of the gut has these small intestinal hairs. I like to think of it, if you like, about like microscopic seaweed almost on the gut wall that helps us absorb and digest food. And those get inflamed and eventually damaged and eroded. And the classical sign is villus atrophy, but it's diagnosed usually historically on combination of blood work and a biopsy to confirm the sign of damage to the gut.
Great explanation. Now, Nick Trott, you are a specialist celiac dietitian. What is the difference between a food allergy and a food intolerance?
Brilliant question. So, food allergy is very important that that's properly diagnosed, usually with an immunologist or an allergist specialist. And what's important from speaking to immunological colleagues, that the history is very important to diagnose a food allergy. So it comes out a combination of blood work, but also a clinical history. So blood work is usually not enough. Often IgE antibodies are involved, but just because someone has a positive IgE antibody, that's not usually enough. It's usually important to see a registered allergist, a registered immunologist with a specialist in allergy, and then the history leads on to a diagnosis of food allergy. Obviously, there are certain cardinal symptoms of food allergy that may present in different individuals. And intolerance is usually, it can be in some ways considered less serious, but I think we need to be careful about how we use that language because intolerances can be very unpleasant and really reduce people's quality of life. Intolerance usually classically can present in the form of a lack of enzymic activity, the most obvious one being a lactose intolerance. So that's where people do not produce enough of the enzyme lactase, and lactose, which is a disaccharide, two sugar molecules together, presents undigested into the colon and can be fermented and cause diarrhea and unpleasant symptoms. So that's a classic intolerance. Now, there are other intolerances that may present in slightly different ways, but there's no evidence-based diagnostic blood test for food intolerances. So one of the things that is pushed out there these days is the idea of IgG4 antibody testing. There's unfortunately very little evidence to support those tests. I've had multiple patients in my clinic who have undertaken those tests, sometimes multiple of those tests, and get different results, or patients that don't have intolerances at all in the classical sense getting positive results. And those IgG4 tests can result in restrictive diets for no reason. The basic scientific way of diagnosing the intolerance is usually with a history, clinical history, careful clinical history, and then an elimination diet approach. Hopefully in the future, we may have more accurate biomarkers. And I always keep an open mind about this. So it's best to sort of have what I would describe as epistemic humility. So just keep an open mind about how we may be able to diagnose intolerances in the future. But there are, hopefully I've explained differences definitely between allergy and intolerance.
Great explanation. Now, Nick Trott, as of this recording, I'm 65 years old and I have been gluten-free for 31 years. It can be done. And I can remember years ago getting a lab test and testing my sensitivity to gluten on a scale of 0 to 100. I was a plus 100, according to a medical doctor.
Mm.
So I've needed to be gluten-free. Can you explain for our audience what exactly are gluten grains and why do so many people react to them?
Great question. Yeah. So gluten containing grains, that's a good way to describe it because sometimes when we talk to people who present with a diagnosis of celiac disease, they think the grains themselves are gluten. And actually, the grains that contain gluten is way more complex than that. They're natural products, but they're quite biologically complex and chemically complex. There's a lot of different things in there: fats, carbohydrates, sugars, and proteins. And from a nutritional perspective, obviously, I'm a dietitian nutritionist, so I come at it from a food perspective. Gluten is not a sugar or a fat or a carbohydrate. They are proteins. They're non-essential plant proteins. Particularly the true gluten-containing grains, as Catherine, I'm sure you will know very well, are wheat, barley, and rye. So we call them autoimmunogenic grains for people who have celiac disease. And it's very important to say it's not just wheat, it's wheat, barley, and rye. Now, we can get a little bit more geeky about gluten, and I often enjoy doing that. I consider myself a bit of a gluten geek. So in wheat, we would call those gliadins. In barley, we would call it hordins. And in rye, we would call it seculins. So in wheat, barley, and rye, we've got gliadin, hordin, and seculin. Those are the actual gluten proteins. I like to think of them biochemically like brother and sister. So they're biochemically very similar. If we're being very, very sort of like scientific about it, we could call them promalines or proamylines. Last week, I was away at the European Promaline Working Group, which is a group of scientists that study these proteins and their effect on human health. But specifically, they are very similar, and obviously they will cause damage to the lining of the gut in people with celiac disease. Now, oats are a slightly different case, and if you want me to, I can go into that as well in a little bit more detail.
Please do, because so many people who are listening to the Natural Healing Show are trying to be healthy. They're trying to
Mm.
improve their diet, and they may
Mhm.
be sort of doing a hit or miss approach, trying to figure out, what's causing all my GI issues. So tell
Of
us
course.
about oats.
Yeah, you raise a couple of different points, and maybe I'll go into oats, but I think you raise a really important point there, Catherine, we can maybe come back to. So oats are not a true gluten-containing grain. Oats contain a protein called avenin. Now, avenin, if gliadin, hordin, and seculin in wheat, barley, and rye are like brother and sister, avenin is like the eighth cousin 100 times removed. So it's not truly autoimmunogenic as far as we know. There is a very small subset of patients with celiac disease that do appear to have an inflammatory response to avenin. But it's very, very rare. The studies that have been done, there's a very famous Australian researcher, Professor Jason Tydin, who's doing a lot of the research in Melbourne on this. He's done some very elegant studies. And what he's found, there is maybe a small subset. We initially thought maybe 8%, but that may be a slight overestimate. Maybe the most current studies would suggest maybe 3 to 8% of people with celiac disease may have an inflammatory response, but it may not lead to over damage to the mucosa in everyone with celiac disease. So it's kind of one, I know it can be a bit frustrating, but it's one of those watch this space answers, because more research does need to be done, I think, to fully understand this. And Prof. Jason is doing a lot of the work. So hopefully there may be a test we can use in the future that we could say, it looks like you may have an inflammatory response to avenin. But again, we want to treat everyone individually. I think the take-home message for people who do have celiac disease and are reporting symptoms when they consume gluten-free oats. So we have to make that very, very carefully. And some of the regulations globally can be different in this space. In the UK, if oats are labeled gluten-free, they're tested to a regulatory standard of what we call less than 20 parts per million. And then we would recommend them for the vast majority of the people we see in clinic. But if people come back and they're reporting symptoms, they're saying, look, I've introduced gluten-free oats into my diet, or purity protocol oats, I'm having symptoms, then we need to work through them individually, looking at blood work, looking at their symptom profile, and maybe a short period of time when we would actually remove gluten-free oats from their diet and see what would happen. But again, as you said, Catherine, this is such an important point. Oats are a really healthy food to have in the diet. I think they've been demonized somewhat recently for a number of different reasons, and I don't know why. All the evidence would suggest that for the vast majority of people, oats, they contain really good levels of soluble fiber. They can really help people, who have diabetes, regulate their blood sugars control as part of a wider, healthy eating style of nutrition. We never want to think about one food in terms of health, but the global pattern and that individual in context, of course. But I think, for most people we see in our service who have celiac disease, they can tolerate gluten-free oats very successfully.
Now, Nick Trott, specialist celiac dietitian, what is the difference between someone who has celiac disease and someone who is simply intolerant to gluten grains?
Such a brilliant question again, Catherine. And this is one of those philosopher's stones questions that I think we're continually looking into and trying to answer. The important thing when we talk about this is we really know what celiac disease is in terms of its pathophysiology. It's a T-cell mediated multi-system autoimmune condition. And we need to be really clear that we have a good diagnostic pathway for that now. Sometimes we need to think of ways to improve diagnosis of celiac disease. In the UK, that we know only maybe about 36% of people are diagnosed. And this is reflected around the globe. I think there is a number of what we call the iceberg of undiagnosis of celiac disease, because it doesn't always present in the classical way of weight loss and people having gut symptoms. It can present in atypical ways, like sometimes it can affect people's cognitive function. Sometimes it can affect people's bone density or just cause anemia. So we have to be, as clinicians, and we rely often on our primary care colleagues for this, to do case finding. But once we've suspected celiac disease, and I think we need to have a low threshold to test for celiac disease, even if it doesn't seem like a classical presentation, then we need to test for it, and then we can do a proper diagnosis. And we really do more and more understand the underlying pathophysiology. And understanding the pathophysiology hopefully means we may have some non-dietary treatments for celiac disease eventually. Big area of ongoing research. Now, with non-celiac gluten or wheat sensitivity, and I think there is a bit of a terminology issue in this area. So some people will say non-celiac gluten sensitivity. Some people will say non-celiac wheat sensitivity. I tend to combine the two, and I know it's a bit clunky to say both, but I think it better reflects where our knowledge base is at. So as I was saying on, Catherine, wheat itself is quite a chemically complex food. There's a lot of things in there. So yes, we've got gluten, like gliadins. We've also got a lot of different carbohydrates in there. And one of those carbohydrates would fall in, so I'm sure yourself and your listeners and your viewers will know some things that fall into the FODMAP group. Now, don't want to overwhelm people with a lot of info, but FODMAPS is a particular type of group of carbohydrates that can cause symptoms in people who have irritable bowel, or what we call these days disorders of gut-brain interaction, or DGBIs. So for those people, they may report symptoms to gluten-containing grains, because wheat, barley, and rye are high in those FODMAPs, specifically something called fructooligosaccharides, or just fructans for short. So we know when people cut out gluten and they think, oh, I'm gluten sensitive, and they cut out wheat, barley, and rye. Yes, they're cutting out the gluten, but they're also cutting out this FODMAP spectrum. And we don't know always if it's actually the gluten or the fructans that's causing this issue. So it's very important to say, though, that, non-celiac gluten wheat sensitivity exists because the people with those symptoms exist. We don't want to be dismissive of people who are presenting with symptoms. We need to understand their symptoms, categorize their symptoms, and treat them appropriately and support them to feel better and improve their quality of life. But I think it's important to say the best evidence we've got would say for a subset of people, it's not the gluten that's driving those symptoms. It may actually be the fructooligosaccharides or that FODMAP spectrum of stuff. And then we need to have a discussion about how we dietary approach that in a careful way. There's one other thing I would add in, and again, I'm going to use that phrase. It sounds a bit geeky, of epistemic humility. What I mean by that is being open-minded, because there's a lot of research going on, and we can talk about some of the things that are being done in this area. So there's another group of compounds in wheat called ATIs, or amylase tryptase inhibitors, that are natural things that occur, and they're present in plant foods, particularly wheat, barley, and rye. And for some people, that may be driving it. But again, it's one of those things that if someone cuts out those gluten-containing grains, all these things may be having an effect, a beneficial effect on their symptoms. And I think what we need is, unfortunately, more research, but we don't want to dismiss people with those symptoms just because they haven't got the antibodies to celiac disease. We need to think what's going to help them ultimately and make their symptoms improved and the quality of life improved. So it's quite a complex picture, and I think it helps to work it through with a clinician or a dietitian or a nutritionist with expertise in the area to try and unpick that and help that individual out.
So, Nick Trott, you explained that wheat, barley, and rye are gluten grains. And then we
Mm.
talked about FODMAPs. Can you give us examples for our audience of actual foods that are FODMAPs?
Yeah, so FODMAPS, I often say, has the worst acronym in nutrition and dietetics. Catherine, I'm sure you know it very well, but I'll just say it, and I think it can sound like very complex, but it's not too bad once we break it down. So FODMAP stands for fermentable oligosaccharides, disaccharides, monounsaccharides, and polyols, which is a real mouthful, I know, but all these are carbohydrates. These are carbohydrates that are present in a range of different foods. Now, one way I like to think about this is it's very important if you think you may be having issues with that group of foods. Maybe you've been diagnosed with irritable bowel syndrome, or what we call DGBIs these days, disorders of gut-brain interaction. So we call them DGBIs because we know the brain and the gut are in cahoots. And when you've got a DGBI, the way I often explain it is maybe your brain speaking English, but your gut is speaking Dutch and they're not communicating very well. And so we can approach that in a number of different ways and treat it in a number of different ways. Sometimes it might be medication. Sometimes it might be what we call gastro psychological inputs. So that's not to say it's all in people's head. It's not. But we know that certain like diaphragmatic breathing techniques or yoga or gut-related CBT or gut-directed hypnotherapy can be very helpful for people with these conditions in combination with nutrition. And nutrition needs to be individualized, and it can be very simple approaches to nutrition. And we always want to go with the easiest approach first. Let's not make things more complex than they need to be. But one of those approaches is the low FODMAP approach. And the important take-home message here is this is not something that really should be done independently. It's something that should be properly sort of worked through, because a lot of people with celiac disease that haven't been diagnosed will come to our clinic and saying, oh, I thought I had IBS and I put myself on a low FODMAP diet and it worked a bit, but it didn't work. So it's really important when we're talking about irritable bowel or GI symptoms that people get a proper workup with a clinician and then referred on to a nutritionist or dietitian as appropriate. So we need to be very careful that we work through these steps logically and people don't just jump to taking things out of their diet, or what I would say is a Google low FODMAP approach when they just Googled it. We would all do that. We all got symptoms. We would all go into the internet. We're all very good at getting information these days. But I think with this specifically, we need to work through step by step. So the low FODMAP approach and the low FODMAP diet involves taking a range of different food groups out. And unfortunately, it's not as easy as saying, yes, wheat, barley, and rye are high in fructooligosaccharides. Other foods are high in things like lactose, which is the disaccharide, the D in FODMAPs, which would be milk products. And then you've got polyols, and those are things like sorbitol and mannitol that can be in fruits and vegetables. So I think the thing is, and one of the dangers, and I've actually did some research when I did my master's degree, I looked at this, at the application of the low FODMAP diet, when maybe it was just delivered by a well-meaning doctor or gastroenterologist. And I have so much love and respect for my primary care and gastroenterology colleagues. But what we found is they knew what they were doing, but they didn't have the time to deliver it properly. Unfortunately, as dietitians, we've got more time to individualize it. So I think the take home message with the low FODMAP approach, yes, for a subset of people, they probably can do it independently with some other resources. But for most people, we need to individualize it and we need to take it one step at a time to find out what foods are going to most impact people. The low FODMAP diet is not really a diet, it's an approach. Step one is the diagnostic approach, where we reduce a load of FODMAP foods to see if it's going to work for someone. 2 to 6 weeks, if they've not improved, then they're probably not going to benefit from it. If it has worked to a degree, then we do what I call the FODMAP hokey cokey. So we put one high FODMAP food in, where we take one out, we put one in, and we take one out, and then it's personalizing it. So I think the FODMAP approach needs to be done, again, with support, and make sure we're individualizing it so it's sustainable and it's not reducing someone's nutritional quality, because particularly stage one can have an effect on the microbiome slightly, we think, for some people, and it can induce, some nutrient intake. So it's something to take with support and do carefully with a clinician that understands the area.
So, Nick Trott, I have to share for our audience my personal story about going gluten free. Because,
Mm.
as I mentioned, I'm 65 years old, and when I was 34, I got off antidepressants. And part of getting off antidepressants was going gluten free. And one of the things that many people do not know, and this is a little known fact, that over 90% of your serotonin is produced in your GI tract. And so if you've got all this inflammation in your gut, whether it's from eating gluten grains or FODMAP foods or just simply eating junk, then your brain can't make the neurotransmitters that you need to be calm, to be happy, and to be mentally, emotionally healthy. So changing your diet has a huge impact on your mental, emotional health. And with that, let's take a break and listen to a message from one of our commercial sponsors here at UK Health Radio. I'm your host, Catherine Carrigan, medical intuitive healer, Amazon #1 bestseller selling author. We're listening to Nick Trott, specialist celiac dietitian from the Royal Hallamshire Hospital in Sheffield. We'll be right back. So, Nick Trott, I am a medical intuitive healer. I work with clients all over the world who come to me to solve all kinds of problems. Okay. And whenever I'm working with someone with mental, emotional health issues, one of the things that I always look at is their diet. And I explained my personal story about going gluten free and how that had such a huge impact on my own mental, emotional health. From your own professional experience, what do you notice? What do your clients report about how their mental, emotional health improves when they go gluten free and clean up their gut?
Yeah, so Catherine, it's such an important question to talk about. In my clinic, obviously, I'm seeing people who are specifically often diagnosed with celiac disease. And we do know from the evidence that it improves health-related quality of life. If someone's got celiac disease and they go gluten-free, And particularly people who present with a lot of GI symptoms, they feel a lot better and their quality of life does improve. It doesn't always fully normalize, like we would say, to a level of the normal population. Obviously, some people improve a lot. We're talking about obviously a medium or average when we're looking at the big studies. So we do know it can improve the health-related quality of life in people with celiac disease. I think one thing I would say is that as a species, we've been consuming gluten-containing grains for thousands of years. I think it's important to emphasize for the vast majority of humanity, the consumption of gluten-containing grains is perfectly safe. And actually, we know that consuming gluten-containing grains for most people, it actually has health benefits. It improves their fiber intake. It can improve their overall intake of several nutrients. Here in the UK, bread is a traditional food that's been eaten for a number of years. And we know it can enhance your overall calcium intake. These foods are fortified. We have quite a lot of social deprivation in the UK. And we know that fortified products can actually help with that. So I think when we're thinking about nutrition, we really need to think about the cultural context. Who are we speaking to? You know, we think of often some of the people we will see in clinic, maybe we're coming at it from a Western context, but we're awfully diagnosing people from a wider, diverse population, and social economic disparities come into it. So I think when we're thinking about diet, we need to think about who's in front of us and what they may benefit from it. And actually, a subset of people, you know, certainly most people do not benefit from restricting gluten in their diet. It's just a health restriction or a food restriction they're not going to benefit from. Because we don't digest gluten very well, I think what's happened is one of the messages has been taken away from that is that gluten is inflammatory or unhealthy for everyone. And that's simply not the case. Most people, you know, will be absolutely fine consuming gluten and wheat containing products. A subset of people absolutely need to be diagnosed better. I think in terms of the mental health aspects, I think I can hear my psychology colleagues whispering into my head, because you made this really important statistic about 90% of serotonin being produced in the gut. And of course, as a dietitian, we want to improve people's quality of life through nutrition. I think what I would say is, again, I'm going to use that phrase once more, epistemic curiosity. I'm always open-minded about what nutrition can do. However, I would counsel just a little bit of caution because I've seen people who present to me in my clinic very low mood, very depressed. And these are people that are, you know, healthy, managing their diet very well, exercising, doing all the things, the health style factors that you think would improve their quality of their mental health. And they still need additional treatment. So I think we don't want to demonize psychological input from our qualified psychology colleagues. And we don't want to demonize medications that may benefit these people. It's really important to have an open mind to, yes, you know, health care, physical activity, keeping oneself physical active, eating a quality diet, minimizing obviously things that we know maybe not beneficial for us in the diet. But I think it's so important that we treat people individually and they have the access to the full spectrum of treatment as required. We know that celiac disease can increase the risk of particularly undiagnosed celiac disease can affect mood disorders. And diagnosing people, treating them with a gluten-free diet can be great, but we do need sometimes to refer on. And I'm really hoping that particularly the subspeciality of what we call gastropsych or psychologists that specialize in gastroenterology is going to improve because we know our colleagues can have a massive impact in this area.
So, Nick Trott, in the US, my understanding is that before wheat is harvested in the United States, it gets sprayed with glyphosate, also known as Roundup. And glyphosate and Roundup are known neurotoxins. So a neurotoxin is literally toxic for your brain and can affect your mental emotional health. What is the difference in your professional experience between United States wheat grown and produced in the United States, and European wheat? Because many of my clients who react to wheat in the United States can go to on vacation in Greece, for example, and not have the same reactions. What is your observation?
Well, Catherine, I'm so glad you brought this up. So we recently had the International Coeliac Disease Symposium in Sheffield. We're very lucky to have it here. And this is something that does get raised a lot. So I think we need to sort of break this down a little bit into different groups. And I think, again, I think the global message is that if you've got celiac disease, anywhere in the world, you cannot eat gluten containing products. It doesn't matter if it's American wheat or European wheat. One of the countries that has the highest diagnosis of celiac disease in Europe, because they're quite good at diagnosing it, is Italy. And a lot of people say the claim will be made, oh, I go from the US to Italy and I've got celiac disease and I can tolerate the wheat there. There is no evidence base for that. Gluten is an autoimmunogenic protein. If you've got celiac disease, you will not tolerate the wheat anywhere or gluten containing grains anywhere in the world. Yeah. So I think where this comes from sometimes is some of the production techniques can be different, and that may lower the fructan content of some products. So people who've got wheat or, what we would call maybe those fructooligosaccharide sensitivities may find they can tolerate certain sourdoughs better. The way French bread is produced, it may be produced over a slower period and have an effect. But again, I think that's not universal. And again, I think we've got to be very careful about things like pesticide residues. Those things are carefully regulated. And I think, again, certain advocacy groups, they can demonize these products. I think for a lot of people unnecessarily, it can create a lot of anxiety or food related anxiety. And Catherine, I have seen people who've come into my clinic and they're so fearful around food. They have what I would call chemophobia. Everything's a chemical and everything's going to affect my health. And we really don't want to demonize a lot of foods that are standard, carefully produced for a general public. A lot of the standards out there are absolutely fine globally. And I think a lot of this messaging, in my mind, particularly for people that may have a history of disordered eating or restrictive eating, your foods get narrower and narrower. I've seen people present to my clinic and they have 4 or 5 safe foods. And actually, what I do in my clinic a lot of time is not restrict people, but try to get them to have a bigger, wider range of foods. We're trying to improve their food-related quality of life, which is a subset of health-related quality of life. So I understand people wanting to take autonomy over their health and improve the health through their own behaviors. But again, we don't want to over-restrict people unnecessarily on the basis of that. I could show you a list of what a strawberry is made of. And it sounds like a load of scary chemicals, but actually that's just natural. So I think we've got to be very careful about the messages we take, particularly online. I certainly wouldn't want to restrict people from eating gluten-containing products unless we have an established medical reason for doing it, whether that was in the US or whether it was in Europe.
I totally agree. And there's something called orthoexia. So many people, there's all kinds of eating disorders, as we have heard, but orthoexia is like, I've got to have the exact right thing or I won't eat. And then that's its own form of neurosis. And
Absolutely.
that's not healthy either. Yeah. I
Yeah, we see that. That's so good, Catherine. We see that in celiac disease sometimes, or a variety of it. Like orthorexia, obviously, is a fear of eating foods that aren't considered healthy. We're seeing that present in a number of different ways. In celiac disease, we often see what we call hypervigilance to the food environment, where people are so scared to go to weddings. I've had people say to me, I didn't go to my cousin's wedding because that keeps me safe, or eating around colleagues is fearful because they're worried of cross-contamination. And yeah, we want people to have an awareness of their food environment, but not a hyper awareness. What we want to do is simplify the approach and support people to be gluten-free. I often use this term food-related quality of life, which was established by my friend and colleague, Professor Kevin Whelan from King's College. And one of the definitions is the ability to manage a necessary medical food restriction, but still engage with the social activities that center around food. So much of our social life and way in showing affection of care for people is food centered. And when we talk about food, I don't think we want to reduce it down just to, oh, it generates symptoms for me, or it damages me, or, it's just about getting the right combinations of fats and vitamins, because food is so much more than that socially.
Yes, and you and I completely agree. And here's another personal story. I remember in 2015, my mother and I went on a cultural visit to Cuba. And I remember one of the last days we were there. We were in Havana, which is the capital of Cuba, and we went to a bodega where people went to pick up their food. And in 2015, in Cuba, there was literally a chalkboard, okay? And on the chalkboard, written in chalk, was what people, the average Cuban was allowed to get every month in their food. I literally, I'm not kidding you, I cried for an entire hour after seeing that. Because in the West, everyone gets so frankly neurotic about, is this the right thing? Is it gluten free? Is it organic? Is it this? Is it that? Is it biodynamic? And yet we have to, our first relationship to food, in my professional opinion, is actually needs to be gratitude
I,
because
Absolutely, Catherine. I couldn't agree with you more. The by and large, the biggest problem we have with food globally is malnutrition, overt malnutrition. And obviously, as people in the West, we're very lucky to have. I often think if you can choose the dietary approach that you have, obviously, we're not talking about celiac disease here, which is a medical necessity. But we should be very grateful that we can maybe choose the style of eating that we have, and that's because of modern technologies. And yes, there are some difficulties about modern nutrition. We don't want to discount that, but I think a lot of it has progressed, our society and our ability to maintain adequate health overall. And we do see this social, there's a lot of social determinants of health that I think we need to take into account when we're thinking about nutrition and people having access to, basic adequate, varieties. And we see that in the UK, even with the rise of things like food banks. So I think when we're thinking about nutrition, we need to think about who's in front of us. I work for, the NHS, which is a public health service, and people who come through the door, they may be struggling financially, socioeconomically. So we have to be very, very sensitive to who we see, particularly if we're thinking about a medically restricted diet. But I couldn't agree with you more. Having traveled myself, I totally agree that, I think that can open your eyes to different nutritional cultures, which is always fascinating.
It was absolutely shocking. And at the time, there was photographs on the wall of Fidel Castro, who was still alive, and his brother. So imagine going to your local grocery and the president or the prime minister is on the wall, and then here you're allowed to get this much rice, this much coffee, maybe 6 eggs per month. And
Mm.
it's like, no, we need to start with gratitude. And with that, let's take a break and listen to a message from one of our commercial sponsors here at UK Health Radio. I'm your host, Catherine Carrigan, medical intuitive healer, Amazon #1 bestselling author. We're listening to Nick Trott, specialist celiac dietitian from the Royal Hallamshire Hospital in Sheffield. We'll be right back. So, Nick Trott, let's talk about gluten-free products because many of our listeners may recognize that they have celiac disease or that they're intolerant to gluten grains or they're trying to follow a FODMAP diet, a low FODMAP diet. So, how have food manufacturers improved the nutritional value of gluten-free products? And what role do alternative grains like quinoa and buckwheat, and I also have to say rice, play in this?
Absolutely. So I think one of the things is when I look back through the history of the gluten-free diet and the approach, because obviously it came out of work from a very famous Dutch physician, William Dickey. And during the Second World War, the short story is a lot of it was a childhood or pediatric diagnosis back then. And he noticed during the Second World War, there was food restriction and a lot of the pediatric patients under his care got better. And that's when we elucidated over time the gluten-free approach. And many years later, obviously, we had these diagnostic tests. But when I look back at the history, so I look back at some gluten-free products from the 50s or the 60s, you can see the progression. Now, obviously, taking gluten out of the diet for many people with celiac disease, they're not expecting to have to do that. And it can be such a dramatic shift. They have to sort of learn new techniques, new health-related techniques, self-advocacy techniques when they're eating out. So again, it comes back to nutritional cultural competence and what's traditional for those people to maintain the diet in a sensible way. So like in the UK, eating bread is a big part of the diet. We have a big Southeast Asian population in the UK and Sheffield, and they will have chapatis and rotis in the diet. And again, it's about using gluten-free products to make the diet easier and more sustainable. And traditionally, I think the gluten-free products, they did use a lot of like tapioca starch and rice flour starch. And there has been some concerns about the level of things like metals in those foods. Although in a broad diet, I think we don't really know if that's that bad yet. It's one of those things where we're developing the research. We don't want to demonize those products. But what we have found is over the years, and the food companies that make these regulated products, and I think what we have to do is bear in mind that regulated label gluten-free foods are produced to this legal regulated standard called the gluten-free codex, which is the standard that produce foods to no more than 20 parts per million, no more than 20 ppm. Generally, in a lot of parts of the world, there is slight variations depending on country. So all the raw ingredients have to be tested to that level. The factories themselves, the cleaning protocols are high, the staff have strict specialist training, and then the final products are retested. But what they're doing now is using a combination of more traditional gluten-free grains, just like you were saying, Catherine. So things like quinoa, aramath, teff, and sometimes some sort of sourdough techniques in this area. And what we're finding, this is improving the nutritional profile of those products. So I think the traditional idea, and this is very much the case, that we need to give people the skills, the health-related skills to choose foods that are going to suit them best. So when people come to see us in clinic, we're giving them the advice about how to read a label, look at the nutritional breakdown. And some people will be able to do that already. But for some people, it's a new skill, a new muscle they need to flex when they're looking at products and looking at the nutritional profile and breakdown. So if we can do that, people are going to select products that hopefully support their overall metabolic health. Because with the gluten-free diet, on one hand, we want people to be gluten-free, but on the other hand, we want them to also support their overall nutritional health and their metabolic health. So it's important that people are choosing a dietary pattern that matches that. And again, label gluten-free foods, a lot of label gluten-free foods, what we'll find is they're much lower in saturated fat than they used to be. They're often higher in overall fiber content and lower in simple sugar content. So again, it's about fitting that although into the total diet. We never want to look at one food group in isolation. It's never about what foods are you, individual foods are you having, but the overall dietary pattern and how those individual foods fit. Because again, we want to support people's cultural enjoyment of food. And that may mean occasionally enjoying a gluten-free birthday cake that's a little bit higher in fat and sugar. It may mean going out and enjoying a gluten-free takeaway. So we don't want to sort of demonize foods individually. We want to look at dietary patterns. And again, that's when choosing everyday regular foods that people are going to have in their diet day to day that meet this overall better nutritional profile. And that's where label gluten-free foods can sit. But what we've seen over the last few years is for a certain subset of products in that category is an improvement in their overall nutritional quality.
So from personal experiences, I mentioned I've been gluten-free for 31 years. And when I first went gluten-free 31 years ago, I had to make my own bread and it wasn't very good. Or I would buy this bread that came in like a vacuum pack that tasted like cardboard. It was just disgusting. So everything's so much better now, tastes better, better nutrition. Now, Nick Trott, as you know, some celiac patients go grain-free. What is your opinion on grain-free diets? Uh, do celiac patients do the best on grain-free diets where they get all the grains out of their diet?
So again, I'm so glad you've asked this, Catherine. So we do see people who go completely grain-free. And I think if someone presents like that, I always want to do a workup and find out what's going on for them. Quite often they have ongoing symptoms and they may have heard that certain other grains may cross-react. So this idea of cross-reactivity is really, we do not have enough evidence for it. We do not have enough clear evidence that things like, traditional gluten-free grains like corn or rice cross-react in the same way. There's no evidence that coffee cross-reacts. There's a lot of information online and places like YouTube. And I would say it's people putting forward mechanisms. So they'll put forward a mechanism of this is why you should go grain free without any human outcome data. It's very easy to say, oh, Zyme in corn or coffee has this, that, and other, and cross reacts, and then look at maybe one or two studies that have been done in vitro in a petri dish with some cells or in an animal model. That's not human outcome data in my mind. So we need to separate mechanisms from human outcome data. And again, we don't want to restrict people unnecessarily. Oftentimes, when people come through and they've been on a grain-free diet, they may have what we call non-responsive celiac disease. They may have a secondary diagnosis. It could be pancreatic exocrine insufficiency. It could be SIBO. It could be bile acid malabsorption. It could be a number of different things. And what we have to do is carefully work that patient up. It may be they don't need to be on a really restrictive grain-free diet. It may be that they need other medical support and diagnoses. So I think we need to keep our curiosity. What are the symptoms they're reporting? Why do they feel they need to do it? Why do they feel they may be benefiting for it? I always say if we have the human outcome data for a nutritional treatment, I would support it. Where we haven't got human outcome data, but what we've got is some mechanisms or one or two studies in cells in a dish, that's not enough in my mind for us to completely restrict people. So again, I've seen people that benefit from a grain-free diet, but oftentimes when we've worked it up clinically, they don't need that grain-free diet and they can be less restrictive and improve their quality of life. People don't need necessarily to be on really restrictive intakes with GI symptoms or celiac disease or non-celiac gluten sensitivity. What they often need is a clinician and a medical team, a medical dream team to work through that with them and find out why they feel they're benefiting from it. I would say I've had one or two people as well, it may be worth raising up, that have come to see me that have been on a full carnivore diet. So that's essentially the consumption of only organ meats. And oftentimes short term, they feel better because it's an elimination diet. But long term, this has no evidence to support it. And it can actually potentially, really, really restrict someone's nutrient intake. And so we've got to be very, very careful when people are on these very restrictive diets. We need to understand what's going on. We don't need to we need to understand, yes, they're doing it because they want to improve their quality of life, and we need to respect their choices and autonomy, but then we need to work through it carefully with them to find out why that seems to be temporarily beneficialing them. And a lot of the people I see do not need to be that restricted nutritionally.
I agree. And one of the concepts in natural healing is biochemical individuality. Thank you. I am not in favor of an all meat diet that stresses the body in a lot of other ways. So Nick Trott and I agree. Thank you so much for listening. You've been listening to the Natural Healing Show for UK Health Radio. I'm your host, Catherine Carrigan, medical intuitive healer, Amazon #1 best-selling author. You can find out more about me and my work at catherinecarrigan.com and unlimitedenergynow.com. Our guest today has been Nick Trott, specialist celiac dietitian at the Royal Hallamshire Hospital. You can find out more about Nick Trott and his wonderful work at sheffieldgastro.nhs.uk. And remember, you are a unique individual, and the diet that will work for you will be unique to you. Thank you so much for listening, and we'll see you next time.